Hi, I'm Christina. I'm a social care strategist helping healthcare organizations and social care programs turn outcomes into sustainable investment. I've helped organizations like digital health startups and community organizations translate impact into bottom line value. So if you're doing important work, but you're struggling to show the financial return, this training is for you. I'll walk you through a real world framework that helps programs prove their ROI in a language that speaks directly to hospital finance teams, health plans, and value-based care leaders. We know social care saves lives, but for it to be funded at scale, we have to show how it saves money. Think of healthcare investment decisions like venture capital. Decision makers are looking at risk, returns, and payback periods. So if we can't speak that language, we lose the room. Programs like housing, transportation, and care coordination reduce ER visits, prevent readmissions, and improve follow-ups. But without a financial model, they're often dismissed as anecdotal or unscalable. So this is why I developed this framework, because the problem isn't a lack of impact. It's a lack of structured, finance-forward storytelling. This video will help you create immediate value by helping translate outcomes into financial language, identify cost drivers, and engage in credible, directional conversations with healthcare partners. Builds foundational financial literacy, bridges silos between social and clinical teams, and it gives organizations a common language to start structuring reimbursement. So if you want to set the foundation for long-term sustainable partnerships, you're in the right place. Let's get into it. Let's get this out of the way. ROI in social care doesn't always mean revenue generated, and honestly, it doesn't have to. ROI just means getting the measurable results from the resources that we're spending clinically, financially, and operationally. In social care, ROI often shows up as those ER visits, reduced hospital admissions, and improve HEDIS and STAR metrics, increased patient retention, increased care plan adherence, and lower churn in your managed care populations. The framework I use has 6 components: needs, evidence, savings, business case, risk adjustment, and confidence intervals. So think of this as a bridge between traditional cost effectiveness analysis, which has those rigorous methods but is hard to operationalize, and broad SROI frameworks, which are values aligned but often too diffuse for finance teams. First component is needs. Here, you want to identify specific gaps your program fills. This is unmet post-discharge care, missed appointments due to no transportation, or food insecurity that disrupts medication adherence. So let's take an example. A volunteer-run primary care clinic serving uninsured farm workers might identify high ER utilization due to lack of access to basic follow-ups. So then we have evidence, and that's pull in both qualitative and quantitative data, service volume, pre and post metrics, survey data, like whether or not a patient would have received the support without that service, and notes from case managers. Even anecdotal patterns matter here because they become part of your internal logic model. Now let's talk about savings. Here is where we apply industry validated financial proxies. So the average cost of an ER visit, the average cost of an inpatient day, the average cost of a readmission, missed appointments. Now, there are 3 types of adjustments to make here. You might adjust by acuity if your population has HCC scores 1.5 and over. Their baseline costs are 20 to 30% higher, so your intervention likely yields greater savings. You might adjust by geography. Rural areas have longer hospital stays due to discharge barriers, increasing ROI from services like housing. Or you might adjust by payer mix. Medicare Advantage and Medicaid value different metrics, and that might be the difference between PMPM versus utilization. So let's run through some examples in practice. Example A shows how to turn a free mental health program for uninsured adults into a pitch to Medicaid. Example B shows how volunteer-based primary care can turn a business case for FQHC lookalike status or hospital partnership. These are simplified illustrations. In reality, you tailor assumptions and sources to the local context. Every audience sees value differently. For hospitals, that's value bed turnover, admission penalty avoidance, and reduced discharge delays. For payers, they care more about PMPM, MLR, and quality incentive thresholds such as HEDIS. ACOs focus on shared savings, care gap closures, star performance. Speak their language. A 3.5 to 1 ROI is helpful, but saying that we helped you avoid a $75,000 penalty in readmission penalty per 100 patients lands harder. Finally is your risk adjustment and confidence intervals. This is your financial sensitivity lens. We want to give them 3. Start with conservative. This is modest attribution, lower end proxy values. Then we move to expected based on average performance and local outcomes. Then finally, you're optimistic. That's 5 to 1, high acuity, strong attribution. These bands mirror CMMI, NEJM Catalyst, and state Medicaid innovation evaluation. They will build your credibility. I've featured much higher ROIs on social care on my own podcast, but personally, I wouldn't take those 35 times ROI claims to a pitch deck because these claims start to sound like you're selling snake oil. And even if the math technically adds up, most CFOs, actuaries, and value-based care leaders will discount claims that seem too good to be true. So we're aiming for strategic, grounded credibility. A well-argued 2 to 1 backed by real-world outcomes and caveats will win more trust than a 9 to 1 with loose assumptions. Overshooting can backfire by triggering unnecessary scrutiny, derailing partnerships, or inviting the wrong kinds of follow-ups. Think of these bands as your range of realism. They help stakeholders see that you've considered risk, population variation, and data quality, all hallmarks of a partner who understands the complexity of healthcare economics. Now for my own caveat. Not every program needs this framework. It's highly specialized and a specific tool. There are many other tools and models out there that you can look into. So if you're focused on multi-sector values such as housing stability, education, public safety, use SROI. Use cost effectiveness if you're comparing 5 intervention models in a randomized trial. But if you need to speak to healthcare finance, if you're aiming for reimbursement or contracting, if you or your stakeholders have an urgent need to time to ROI and sustainability, if you deal with multiple healthcare audiences who need tailored value logic, try this approach. The best types of organizations to use this are mid-stage nonprofits ready to move from grants to reimbursement, digital health startups with outcome data but no financial case, community providers who need to partner with hospitals or MCOs. And it's timed well. CMS's 2025 SDOH assessment rule makes financial attribution more important than ever, and this framework will help you quantify impact, justify inclusion in contracts, and prepare for value-based care arrangements that include social care. Finally, this isn't plug and play. You may run into some challenges, and here's how to work through them. First is data access. You may need partnerships to access claims or utilization data. Start by building relationship with those local hospitals, ACOs, or health plans. Offer to share high-level impact summaries or patient experience data in exchange for aggregate outcomes. Pilot a basic data sharing agreement through an MOU or care coordination contract. Next is attribution, because outcomes don't happen in silos. So use logic models to be transparent about what your program likely caused. Strengthen attribution by using time-bounding analysis. So look at outcomes 30 or 90 days post-intervention, using comparison groups if feasible, such as clients served versus waitlisted, documenting supportive interventions, but making clear what yours controlled. You can also use an equity lens. Serving high-need communities often creates a delayed ROI. Populations experiencing complex social barriers often require more time and trust before clinical or cost-related improvements appear. These are not short-term fixes. So account for that by extending your ROI analysis timeline to 12 to 24 months if needed. Include qualitative or equity-aligned metrics like housing stability, care adherence, or engagement. You can also frame ROI as a cumulative gain. Investments in high barrier populations do yield compound returns when sustained. Finally, we come to sustainability. Don't build your model on grant logic. Build it on revenue logic. Use this framework to help you with design pricing by patient or episode, model cash flow over time, pinpoint that time to break even, and pitch to finance teams using net benefit, not just social good. And that's how social care moves from being a pilot to a line item. So this is a great framework for you to get started, especially for those early stage programs, pilots, and social care programs without deep financial infrastructure. But there actually comes a point where actuarial expertise becomes a strategic multiplier. As programs scale beyond 2 million annually, or as you pursue risk-bearing contracts or extend into multi-year projections, this kind of support becomes essential to validate assumptions, stratify risk, and model uncertainty with the statistical rigor that healthcare payers demand. But in the meantime, this framework will meet you where you are. It's accessible without actuaries, and it evolves with you as your financial sophistication and partnership opportunities grow. Thank you so much for watching. Thank you for doing this work. And if you want extra help or if you need a little more hands-on, please reach out. I'd love to help get your program funded. I just wanted to ask if you found this video insightful. And if you did, please click on subscribe so that we can continue to ensure no one gets left behind in the value-based future of healthcare.